Did you? I know you guys, Frank, you guys had that crazy rainstorm a while back, about a month ago. It didn't hit us at all, barely. I mean, it rained, I guess, but I
Yeah.
saw like streets like 2 feet, three deep underwater in San Diego. I was like,
Yeah,
holy
yeah, there were a
moly.
couple areas. There were a few, relatively small areas, but it's a big deal for the people who live there, right? It's
Yeah.
still a challenge. Yeah, yeah. So some people really, yeah. Oh, sorry. Am I supposed to? There. Yeah, it was tough, man, for the people that were. My car was in about a foot and a half of water, right on our street. And I was like, you know what? I don't want to deal with tow truck and insurance and all that fun stuff. I'm just gonna jump in and drive. I'm still here. I'm still here. I'm here to talk about it.
I know.
I'm
I
not saying
think
it
I
was the
was on the
smartest
phone with
move.
you and you like ran out. You're like, I gotta go. I think my car's underwater. And you like hung up on me and ran out the door. I was like,
Yeah,
okay.
but there was no damage at all. So it was maybe wasn't a foot and a half. Maybe it was closer to, whatever, closer to a foot,
Wow.
but it's good.
Hi, Dr. Gonzalez. Thank you for joining. Good afternoon to you as well. Hello, everyone else. Thank you for joining. We'll get started here in just a moment. We'll give it just a couple minutes for everyone to get on. For those of you that don't know, that are new to our webinars, you will be on mute and your camera will be off. We'll talk about how to answer questions here in a moment, but know that that is what it's supposed to do, and that you don't have to look for the hide camera button that everyone looks for as soon as they jump on.
Cool. Where's everyone tuning in from tonight? Go and drop your location in the chat. I'd love to see where we've got. I know Frank is from San Diego. I'm from a little town just east of him, a couple hours. Trish is in faraway land. So we got three. I'm just kidding. Trish, where are you from?
I'm in Indiana.
Indiana. I always forget that. I don't know why.
Yeah, yeah, that's okay. I know Dr. Chapman's on here. He's from West Virginia, so he's not far from me. It's like Tennessee.
Murfreesboro? Interesting. I've never heard of that. It's hard to say. Dig it. Jackson, love it. Raleigh, sorry. That was my California accent coming out there. My apologies. Santa Ana. Wow, you're not far at all. You're the third leg of the triangle from San Diego. Ramona, good stuff. Cleveland, Dexter. Nice. Hey, Donnie, nice to see you. Glad you can make it. Awesome. Lubbock, Texas. Yeah, we got folks all over the place.
Yeah.
Mm.
Stoked you guys can make it. Cool.
A few people around me enjoying the warm weather today. Dr. Below, I imagine you had warm weather in Cleveland.
So it's probably warmer there than it is in Southern California, or at least it was.
Yeah, go ahead, Ted.
Cool. Hey guys, we're gonna get started in just a moment, but we are providing CE tonight. Awaken Sleep's doing that, so I just got to give a couple of disclaimers. So at the very end of our session tonight, yes, you do have to make it until the very end. I'm just kidding. You only have to make it till 6 o'clock. Sorry, 5 o'clock Pacific Standard Time. 1 hour or 56 minutes from now. I'll put the CE link in the chat at that point in time and you can take off. Now, I'm willing to stay until there's no more questions, so we might be here a little bit later, but if you need to get going promptly at that time, you can because the CE link will be in the chat. Once you complete the CE survey, which will take you roughly 42.7 seconds, you will get an email in your inbox within 1 to 2 minutes. If you don't, check spam. If you don't see it in spam either, go ahead and go to our website, awakensleep.com, use the little chat portal in the bottom right-hand corner, and say, yo, I need a CE certificate. Our team will be more than happy to help you out. So at the very end of tonight, we're sending a survey link, 42.7 seconds to complete it. Check your email, check your spam, and you should be good to go. That is how CE will work this evening. I think that's all my disclaimers.
Excellent. Alrighty. Well, I think we'll get started here now. There are a few more people joining. Just a little bit of housekeeping before we get started, including Chad's disclaimer there. Welcome, everyone. Of course, we're so happy to have you join us this evening. The best way to view the webinar is actually to go to the speaker view. So up in the upper right-hand corner, you can click view and you'll get a side-by-side of the speaker and the PowerPoint today. Like I had mentioned, your camera will be turned off and you'll be muted for the duration of the webinar. If you do have any questions throughout the webinar, feel free to raise your hand and Chad can unmute you, or utilize the chat box. So we'll be monitoring that regularly. Like Chad has said, if we miss any questions throughout the webinar, we're happy to go back and answer those at the end. So stick around, keep your questions then too. We're happy to spend as much time as we need to get everything answered for you. Our topic today is 3 tools to screen 82% of your sleep patients. Like Chad had mentioned, stick around till the end so you'll receive that CE credit. Thank you to Awaken2Sleep for providing that tonight. And you'll also receive a promo code on our dorsal appliance. So stay till the end, you'll get all that information at that time. There's a few new faces on here, so I do want to pass it over to Frank to talk a little bit about True Function before we get started.
Thank you, Trish, and Chad, thank you so much for joining us today. Everyone, thank you for joining us this evening. Just a little bit about True Function. We started this thing about 25 years ago, so we are on our 25th anniversary. We're super happy and blessed to be here with you. And over the years, the real goal of what we do has really not changed. It's about taking care of you and helping you be successful when you're treating your patients with oral appliances. So we'll continue doing this, offering educational opportunities, offering you expert technical support, and the best products possible and service. So yeah, we're happy to have you again. Thanks for joining us, and looking forward to working with you.
Excellent. So we've officially been hosting our webinars long enough that we have our first returning guest this evening. So I'm so excited to have Chad join us. Here at True Function, we work closely with Awaken2Sleep to help our clinicians take their sleep practice to the next level. So thank you again, Chad, for joining us today. A little bit about Chad. He just received his MBA and is the Director of Operations and Coaching at Awaken2Sleep. He embarked on his journey through education, business development, and the dental industry that led to dental sleep medicine. Since 2018, he's coached hundreds of dentists and teams nationwide and is the architect behind the Sleep Hero Network Online Academy. Using his experience, Chad coaches dental practices to build successful dental sleep medicine practices. As someone who struggles with obstructive sleep apnea, he's deeply passionate about raising the awareness of the significance of this health concern. As a national speaker and educator, Chad's mission is to equip others with tools to ensure success for all stakeholders. So I'll pass it over to you, Chad, to get started for the webinar this evening.
Awesome. Thank you. Tonight, folks, we're going to be diving into 3 tools. I'm going to give you the 3 tools now. I'm going to go into them in the next 50 minutes or so, but they're going to be our medical history, an intraoral screening protocol, and then last but not least, a workflow to how to take that to the patient and actually get them to test. So we're going to go into depth in all of those different pieces tonight and give your team some very practical verbiage and tips inside of the workflow. Now, I like to refer to dental sleep medicine as a dance. When it comes to the dance, we know there's 3 pieces to the puzzle. We have to identify those who are at risk. We have to assess the presence and severity of the condition. And then third, we have to treat patients when clinically appropriate. Today, we're going to be talking about the very first step in that dance called identifying those who are at risk for sleep apnea. To do that, though, I want to kind of break the ice a little bit, show you guys a funny little video that I think is doing a great job of spreading awareness to this disease to the rest of the world. So go ahead and pay attention to the screen. We'll get started with a little laugh.
I suffer from this thing called sleep apnea, okay? If you don't know what sleep apnea is, just ask one of the nurses inside the building. They'll tell you. It's a form of snoring, only it's worse. It's worse than snoring. I choke when I sleep, and I'm loud. I'm so loud that I wake myself up. And you gotta see the way I sleep, it's disgusting. Like this is what I look like when I sleep. Ha. Ha. Who is it? Who's out there? I didn't know I had sleep apnea. My mom told me I had sleep apnea. I was asleep at her house about 6 years ago, sleeping in the guest room, the same way I always do, just like this. Ha. Ha. And I woke up, my mom's at the foot of the bed like this. Oh my God, Jose. You're dying. I go, Mom, I'm not dying, I'm snoring. Joseph, that is not snoring, you look like this. Joseph, you have to go to a doctor and get that checked out. I'm telling you, you're going to die, and I don't want you to die, Joseph, because I'll die of heart attack if you die. Oh my God, Joseph, get that. Mom, I'm not going to go to a doctor for snoring. How long are you watching me? That's creepy. And I kicked her out. Get out of here. Get out of here, Mom. I'm sorry, Joseph. I did not mean to startle you. It's just that I was walking to the kitchen and I heard a noise coming from the guest room. It sounded like someone was killing a bear. And I was like, I don't have a bear. So I opened the door and I noticed that it was just you, Joseph. Snoring. So I'm sorry. You don't have to go to a doctor. Just go to sleep. Go to sleep. And die.
That's Joe Coy, folks. Comedian. He has a great bit on here, and his mom's a little right. For me, and you can check out my full story some other time, but I worked in a dental practice, and the first time I learned about sleep apnea, I was a $145 soaking wet, 5'10", in decent shape, and they said, well, you just snore. Why don't you go get an over-the-counter snore guard and treat your snoring, and you'll be just fine. It wasn't a few months after that that I almost drove my car into the center divider on the freeway, having nothing in my system beyond water and coffee, and a little bit of sleep deprivation and moderate sleep apnea. I fell asleep while riding my motorcycle, which I didn't know was possible, and eventually got treated for sleep apnea with an appliance, surgery, CPAP, while I'm in braces right now. So thankfully to my surgery I did, my AHI went from 23 events per hour down to 5, or just under 5 events per hour. And so when I talk about sleep apnea and finding patients who are at risk, it really matters to me because unfortunately I went undiagnosed for an additional couple of years because I don't fit the stereotypes. Now I have gained my honorary 20 pounds in marriage, I like to say. And so that exacerbated my sleep apnea. But when we look at my story, how many patients are like me in your practice who you don't see? Our data shows that if you screen 82% of your patients, which is very reasonable, that over 33% of them will actually come back with the need for a home sleep test. I would not be here today. I'm confident in saying this. I would not be here today, married to this woman with a baby on the way, with these 2 cute 4-legged freeloading dogs and my little niece who's a punk, being able to do the things that I do and live my life had it not been for my treatment of sleep apnea. And so when we talk about this identifying process, your conversation with the patient may not lead to the outcome of appliance therapy. Hopefully it does, if it's clinically appropriate, but it may just save a life. You might find a patient who has an AHI of 7 who's just tired all the time, or as some of our practices, you might see a patient who comes back with an AHI of 115, and the only reason they're not dead is luck. And because of your conversation with them, they might have a second chance at life. And so while we have some fun with it, we're going to talk about some really cool stuff here. It is really important. So let's do our first verbiage tip of the day. That is, we don't want to screen for sleep apnea. The reason is that no one has sleep apnea. Just ask them. If you ask 10 patients if they have sleep apnea, 9 of them will say, I don't. And 1 of them says, well, I did, and then I stopped using my CPAP. Patients just don't think they have the disease because they've self-diagnosed themselves. So looking at this equation, the first verbiage tip is that we want to make sure that we screen for an airway concern. The dentition is one of the 2 openings to the airway, or I guess the mouth and the dentition is in one of those two openings. And so when you're talking to your patients, it makes sense that you're concerned with the airway because that's your specialty, the oral cavity. So should you be screening for sleep apnea? Well, the ADA in 2017 said that you should. They didn't say you have to they didn't say that you have to test for it. They didn't say that you have to treat it, but that you should be involved in screening for sleep-related breathing disorders. Notice that even they did not necessarily say sleep apnea, but sleep-related breathing disorders. Later in 2019, they would publish an opinion that states that you should also have testing equipment in-house to evaluate the efficacy of your treatment, but that is an entirely different webinar. So check out the ADA position in 2017 as well as 2019 for screening and testing for sleep apnea. Tonight, we are going to go through a very detailed workflow. And in the bottom right-hand corner, if you've got your phones, you can pull out your phone, scan the QR code on the screen, and pull up a full version of this workflow. And we're going to be going through that medical history component, some forms I'll give you with another QR code in 2 slides. We're going to be going through the intraoral screening and the actual verbiage and workflow on how the hygienist can have this conversation without being upset with you that you added something else to their schedule. I was just talking to a hygienist the other day and recounting how screening workflows were the #1 cause of death threats in my life, specifically from hygienists, because they don't want any more in their schedule. We're going to talk about a workflow called the 3 Favorite Things Protocol on how to do just that. Make sure your hygienists are happy with you. So let's jump into the actual workflow. If you need these forms, I've sent them over to Trish and True Function, so they can shoot them over in a post-webinar email, or you can email me at chat@Awaken2Sleep. I'm happy to get you any forms you need. With this, just know that every single person on your team has a part to play. It's not just a doctor or just a hygienist or just Susie May up front. Everyone has a part to play. I want you to consider the statistic that in order to make a decision, the average consumer has to hear something 7 times. So the question is, how fast or how long does it take your patients to hear about their airway concern 7 times? Most practices, it takes 2 to 3 years because they only bring it up on their medical history and every once in a while their hygiene check. With this workflow, we're going to get as close to 7 opportunities to discuss this with the patient, put the airway screening in front of them, and get potentially up to 7 times in a single visit, which means even if they don't say yes in this visit to a home sleep test or your third-party testing solution, that the next time they see you, they very well might, because you've brought it up and you've helped them identify it's a problem. So talking about the front office, and one of the most important pieces beyond medical history is a screening form. Now, I'll be honest with you, screening forms are a valuable tool, but oftentimes they stumble practices up because it takes too much time to do them. It takes the patient extra energy, and they say, I don't have sleep apnea on the form, which again, now we're working backwards, we're working against the grain because they've already self-diagnosed that they don't have it. So this is one form that we can incorporate into our hygiene check that you can use. Again, if your hygienist is already capped out, maybe not, but other forms are the Epworth. You can also use a Mallampati, which we'll talk about in a few moments, and a number of others. If you can incorporate it in your medical history, then maybe don't do it. They're valuable tools. You should be screening from medical history standpoint. We'll talk about that in just a moment. But forms can get in the way a lot of the time. Now, when you enter treatment, that's an entirely different conversation because medical insurance often requires that we do incorporate forms into our intake process to verify that there is a problem. So again, if you have questions about that, that's a different webinar, but that is something you can do. So I want to draw your attention to the bottom part of this slide, and we're only going to pause here a moment. I do encourage you, take a picture of this. This is that bottom part of that Awaken2Sleep screener. And here, what I love about this questionnaire is that it doesn't really care about excuses. So if you take a look at that first question underneath the answer yes or no section, it says, have you ever been told that you stop breathing while asleep? Well, here, what if you've got a young adult who's in college, who goes partying all the time, says, well, yes, but it was actually only because I had a couple of drinks at night. It wasn't really, a legit situation. Well, in this form, you can see it says, well, if yes, please explain why. No, it doesn't say that because this form doesn't care about excuses. yes, obviously there might be extenuating circumstances, but whether it's brought on by alcohol or anatomy or any number of other factors, you might have sleep apnea. And so we need to see if this patient is at risk for an airway concern. And this questionnaire does that very, very well. So I encourage you, if you have already scored yourself on this, answered yes, take the number next to the questions you said yes to and drop your score in the chat. From there, if you need a home sleep test, we've got lots of partners who provide those. Maybe your office has those as well. Definitely get a home sleep test if you're above an 8 in your score. This is one of those ways that we will actually screen more patients effectively. It's an objective questionnaire that allows us to get around a couple patient objections right away. Now, beyond that, at the front desk, I want to talk about 4 major comorbidities of sleep apnea that are already on your medical history right now. And I am going to ask you to put some numbers in the chat like I just did a moment ago. The question I want to ask you is, out of 5 patients that you see every day, how many out of 5 are going to come back with one of the 4 signs or symptoms, medical comorbidities that I'm about to share with you? Now, before I share those with you, I want you to know, first, you got to know that this does not show causation. Okay, this is correlation, not causation. So if we look at the second to bottom statistic, hypertension, 37% of people who had high blood pressure also had obstructive sleep apnea. This study does not show that sleep apnea causes high blood pressure or vice versa. I will say there is data that's coming out to validate that idea, but that's not what this study shows. This is just correlation. Claude, thank you for putting it. You have 5 out of 5 patients. You have a lot of patients, my friend, who need a home sleep test. So all hypertension, 37%. The second I want to show you is type 2 diabetes. 7 out of 10 people in your practice with type 2 diabetes also have obstructive sleep apnea. Going up a little bit, 77% of patients with obesity, that is almost 8 out of 10 folks, and 83% of patients with drug-resistant hypertension, 2 or more medications to manage their high blood pressure, also have obstructive sleep apnea. 83% of them. That means that if you have 10 people show up to your practice, or 5, 4 out of 5 of them that have hypertension like this also have obstructive sleep apnea. This medical history component is critical because it allows us to pre-screen our patients and ask our patients if anyone has ever talked to them about their airway health. Again, not sleep apnea. Also, got to pause. Claude, 5 stars for participation. The other 22 of you, I'm a little sad. No one put their numbers in there. Out of 5 patients, how many you see? There's going to be a couple more participation questions. This is your warning. Please, thank you, Daniel, Stuart. Oh, you're way reduced. That's okay. Go ahead and put some more numbers in there, folks. We're going to have a couple more questions for you later today. We appreciate all your participation. So those top 4, hypertension, type 2 diabetes, obesity, drug-resistant hypertension. If our front office sees any of these, what I want you to do is either build an automation in your system or on a paper route sheet or on a clipboard, write the letters AI in the corner when we're handing off to hygiene. This is going to allow them to know that we need to have a conversation with them about their airway based on something that was covered at the front desk. This will help prepare them and get them mentally ready to have that conversation. Now, hygienist. Again, no one, if you're a hygienist on this call, it'll be okay. I'm going to show you something. It's going to be a 30 to 45-second conversation. I promise it will help. Now, when you're talking to patients, though, you've got to figure out which one works best in your workflow. Frankly, the form that works best is the one that you're actually going to use. It's not about which one is most clinically validated, and that can be helpful and fun, but what one are you going to actually do? If you're not going to use it, well, then let's set it to the side and find other methods to bring this up. There's plenty of reasons to talk about airway. I just gave you a bunch of them in medical history. But besides that, which one helps you start the conversation? That's the question you got to answer. The second thing is patient-centric screening. We're about to dive into the intraoral exam and different signs or symptoms that we can see just in the oral cavity. But when we're talking to patients, we've got to use words that they understand. No one, actually, this is probably the worst example. No one knows what bruxism is, and I would venture to guess that a lot of folks do. But when we talk about malocclusion or we talk about gastrointestinal reflux disorder, just say GERD or acid reflux. Use words and verbiage that connect to patients and their pain. That's going to be tremendously valuable in your screening conversations. So after the patient comes back, and if you've downloaded the workflow document, you'll see they're screened at the front desk with medical history. They're the AI in the route on the route slip. They're handed off to hygiene. We're going to probably talk to them, catch up with them, see what's going on in their lives, because hygienists, patients see you more frequently than any other healthcare provider, probably for most of their lives. You have more connection with them than they do some of their family members. And so you're going to get to catch up on what's going on in their lives, and that will reveal some insights. We'll go into that a few minutes later. But when we sit down in the dental chair, we also have, between an oral history that we've conducted ourselves from being a repeating patient or an exam we can do really quick, we can see a variety of intraoral signs. Now, the first one is intraoral crowding with soft tissue. When we look at this idea of the box of a mouth, it's a very popular idea in airway conversations or sleep apnea curriculums. But the box of the mouth is this idea that if our mouth is a box, then we can only put so much stuff in the box. If we poke a hole in one end of the box and on the other end of the box, and there's too much stuff or soft tissue structures in this example, then air can't pass through from one hole to the other end of the hole. That's the exact same situation we run into here. If we see large tonsils, elongated uvula, or enlarged tongue, then we know that this patient might be at risk for an airway collapse. Now, I'm going to talk about tonsils for just a moment here. I'm sorry, uvula for just a moment here, because if you ever see a uvula drops below the base of the tongue, it actually is indicative that there might be an airway issue. See, that uvula stretches over time as air pulls on the uvula from a partially collapsed airway and a negative pressure system. Pulls on the uvula, dragging it down. So that's why one of the surgeries to treat sleep apnea is to just cut it off. So elongated uvulas are a fun one. I know they're not as common, but then they're very indicative of a sleep concern or airway concern. Another tool in our belt is the Mallampati, designed by, you guessed it, Dr. Mallampati, and is often used to determine if a patient is at risk for an airway collapse while under anesthesia. And I can't say that word very well. It must have been the last time I went under for surgery. With this, class 1 and 2 are considered to be not at risk, while class 3 and 4 are considered to be mildly or moderately at risk. When you're doing this, make sure that your patient is sat upright and they stick their tongue out all the way past their lips. Very important, past their lips. Last, make sure they do not say the word ah. Ah will actually invalidate the test because it's actually creating tension back to the throat, raising the soft tissue structures, and not giving us a very clear assessment to look at the crowding in the mouth. The biggest thing we're looking at here is the base of the tongue to the soft and hard palate. Class 1 and 2, we can clearly see all the structures in the back of the mouth. Class 3, we really can't make out a lot, but we can at least see back there. In class 4, we might not even be seeing the soft palate at all. It depends on how severe the class 4 is. And then class 5 is a really great joke for patients who are in bad need of a home sleep test, okay? So let's jump into our other signs and symptoms. We're not going to go through all of these, but this is a pretty comprehensive list of the signs and symptoms related to an airway concern that you can find in a practice. So you can find studies, just look up that term and screening or prevalence to obstructive sleep apnea. You'll see it pop up. There's tons of data on this. One of my favorite, because it's kind of fun, is acid reflux. Looking at this, we see yellowing on the tongue. And so we need to determine, is this acid reflux or is this stain or residue from our patients? In order to do this, I do recommend that you warn your patient, unless you don't like them, in which case, don't. But what we're going to do is we're going to take a cotton swab or a dental probe. We're going to lightly scrape the top of the tongue with that tool. Again, if you didn't warn them, just be prepared for a pop because they're surprised. But assuming we did warn them, they'll stick their tongue out, you do the whole deal. And if the yellow residue comes off, that means that before their dental visit, they were thinking about you, went to Starbucks or the donut shop, got the cream-filled donut, the cup of coffee, chowed it down, and then walked in for their cleaning. I want you to think about it like this. Residue means they were thinking about you. If it is stained, then it's acid reflux. And no, I don't have a rhyme for acid reflux. I have had several offices submit rhymes for prizes, and they're very, very long. So just remember, residue means they're thinking about you. Stained means they probably need a home sleep test. There you go. So that's acid reflux, and we have objectively verified that it is related to an airway problem. So how does that work anatomically? Very simple. When an airway collapses, typically in the posterior hyperpharynx, it causes pressure to build in the throat. That puts pressure right about here on what's called the esophageal sphincter. It's a very hard thing to say 5 times fast. I dare you to try. That valve, the sphincter, is responsible for keeping the stomach from leaking stomach acid. When pressure is met on that valve repeatedly over time, the valve weakens, allowing acid to crawl up the airway and eventually stain the tongue. So it is the result of an anatomical problem and specifically related to their airway. Okay? Next up is bruxism, one of my favorite signs and symptoms to talk about because 70% of people who grind their teeth also have obstructive sleep apnea. When tested further with a flat plane occlusal night guard, 50% of those who had sleep apnea and bruxism had worsened apnea with the night guard. So when we look at this, we recommend, especially from this point forward, if you haven't already talked to folks about it, make sure that you rule out their airway as a factor in their treatments. If you put a night guard into a patient's mouth and make their apnea worse, then we've just done, after this presentation, we've done a poor choice there clinically. We want to make sure that we rule out the presence of apnea and find an appliance that's dual rated for bruxism and sleep apnea. There's plenty of options out there. I'm sure True Function has some great appliances, but let's treat 2 birds with 1 stone, 2 concerns with 1 stone. And at least in my situation, when I got treated with my first appliance, I found out that by treating my apnea, I stopped grinding my teeth. The same mechanism that causes the grinding for patients with apnea also causes scalp tongue. So if you think about this, the airway collapses, our body drops 3 to 4% oxygen, depending on which guideline you're using. Our heart rate increases typically, anywhere from 20 to 60 beats per minute. And then our body releases adrenaline and cortisol into our system because something is going on. The alarm bells are sounding. And so what happens is we're in this semi-conscious state where we activate the muscles in our jaw and we clench and grind. For me, 22, 23 times per hour. Then the next thing that happens is our tongue is activated and the tongue is being thrust into the back of the teeth 20 to 23 times per hour for me. Some of your patients, again, as low as 5, others as much as 60. But this happens repeatedly every night for anywhere from 5 to 8 hours a night. It would make sense that we see additional wear and tear and scalloping on the tongue. And so we see scalp tongue and bruxism. Next up, we have the high vaulted hard palate. Now, this one is interesting because we see that we're going back to that very simple idea of the box of a mouth. If the box is smaller, well, then we're more likely to have a collapse because we have certain things that the body needs, like a tongue, tonsils for most of us, and just our general anatomy. And so if the box is smaller, we know that there's a higher risk for collapse. That's why orthodontics in children is just such a great thing as relates to expanding that part of the airway and that airway focused ortho treatment. I'm not going to say much on adult palatal expansion. Obviously, there's some mechanisms for orthodontics and having potential to help out, but you'd have to do your own research on the clinical implications of doing adult palatal expansion, things of that nature. Last but not least, for our intraoral component tonight is our intraoral or tonsil crowding. The picture on the bottom right-hand side is what I like to call a great referral. Someone that probably needs help with an ENT to cut those things out because you can barely see back there. And it's likely a huge pain point in their lives. The person on the left has some pretty large tonsils as well, but they're probably someone who'd be a fantastic candidate for an appliance. Now, I will say, neither of these are my tonsils, to be clear, because that would be really weird. But you can have large tonsils and be effectively treated with an appliance. While I did pursue surgery, my appliance got me down to that same sub-5 score without surgery beforehand. I just have been trying to get my tonsils cut out for over 10 years. And so my sleep test was finally the thing I needed to actually move forward with that treatment path of getting a tonsillectomy. When it came to asking my doctor to help out, he just said, well, do you have sleep apnea? To which I said, literally, this is the actual, look at my screen for just a second. This is the actual mechanism of screening he employed. Ready? He asked me the question and I went like this. Nope. And that is what we call effective screening in medicine. I'm just kidding. Obviously not effective screening, but that is legitimately the last and only thing he did to screen me. And so we saw that this home sleep test I did because of Awaken2Sleep that you can do in your practice actually helped me get that far. Daniel asked, how was your post-operative healing for tonsillectomy? If you're ever looking for something completely debilitating, I recommend tonsillectomy, 5 stars every single time. It was incredibly painful. It was the most painful thing I've ever done in my entire life, frankly. But I lived and I have less sleep apnea, so it was worth it. Also, I had great insurance, so it didn't cost me too much. So looking at that, we're going to kind of wrap up this intraoral sign, and we're starting to get this picture of what it looks like to screen our patients intraorally. Now, here's the deal. I just took about 20 minutes to go through all of that information, but you as a dental professional are able to see these things sometimes without a patient opening their mouth, from what I've heard. So when you see a patient who's talking to you, who you've seen in the past, you're already aware of these things you've probably identified in your previous intraoral exams. So it won't take you but a few moments to pick out a couple of the things that are going on and bring it up in a conversation to your patient. Now, with that, we're going to combine that medical history and the steps we talked about in that conversation, paying attention to the indicators in their personal life or subjective complaints that are going on. That could be memory loss, impotence, morning headaches, chronic fatigue. That could be drowsy driving. It could be any number of things that are impacting the patient's life. It could be that Joe really doesn't like having to drink a cup of coffee after 3 p.m. because he finds it hard to sleep, but he can't stay awake without it. It might be that Susie has a hard time driving her grandkids after 2 or 3 o'clock in the afternoon because she's feeling tired and their safety is of the utmost importance to them. These little conversation pieces, these little life changes are the gold that can help you help a patient by connecting that pain to what's going on in their lives. So this is kind of that's that first part. The first two tools I mentioned are medical history, our front office workflow, and our intraoral screening. The next thing we're going to talk about is a protocol. And really, well, screening doesn't matter if we don't get patients tested. So how do we get patients to test? Now, before we move on, Joe Coy mentioned sleeping like a bear. So I figured this is an appropriate image. But I want you to today, tomorrow morning, when you go into your practice, assuming you work on Wednesdays, I want you to take a few moments and actually screen your team. Take a few moments and have them open their mouth, have them fill out a questionnaire, and just make sure that you take care of your home team first. The only reason I was able to get treated for my sleep apnea was because I got screened as a part of the team here at Awaken2Sleep. The dental practice I worked at missed me. Awaken2Sleep got me because every single team member is required to be screened and be tested. And if you have a home sleep test, I cannot recommend this enough. It is worth whatever amount that home sleep test costs. Test your team, because you never know who's missing out on a diagnosis because of that home sleep test. So I want to pause real quick. We're going to transition into the workflow component. This is Sky, one of the Wooters pups. Any questions, comments, concerns, or cries of outrage about anything I've discussed so far? All right. Well, then let's jump into our workflow. Before we do, I want to show you one more video that's going to highlight a very important philosophy that goes into our workflow here. So go ahead and pay attention to the screen and we'll get started.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
No, see, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Oh, come on. If you would just...
Don't...
Try to see things my way.
All right, folks. So what about our patients? How does that apply? Well, because sleep apnea, airway concerns, other dental considerations, other dental concerns, they look like the nail on the head. And just like the video explained, it's not about the nail. In fact, it's in general about the pain that they're going through. And so we're going to go into our workflow, and to demonstrate this best, I'm actually going to stop sharing my screen, and we're going to kind of go into a role play situation. Now, to role play on a webinar is a little bit weird because I am one person. And usually role plays involve more than one person. So I'm going to do my best in this time, in the next 15 minutes, to really break down this workflow and show you what every person does. So when I'm on this side of the screen, I'm going to be Chad the hygienist. When I'm on this side of the screen, I'll be Dr. Smith. And then when I'm in the middle, I'll just be normal old Chad. I'm going to do this whole deal right here. That's my clacker, as if we're, acting. And so that'll be when I initiate what the script is and in between explaining what the workflow looks like. Additionally, this protocol is designed to be quick. That said, doctors, you have the greatest capacity to break this workflow. So we're going to be talking about that in a few minutes. Additionally, I want you to understand where this workflow is going to end up. We're going to take a patient through the front office, all the way through their entire hygiene check, and look at how that patient can get to a home sleep test. But before we understand the process from getting from A to B, we have to pause and talk about home sleep testing. Whether you believe in operating your own equipment, using a third party, referring to physicians locally, that we can talk about that anytime. If you want some more information on it, I'm happy to work with you on understanding the pros and cons of each of those models. But what is most important to understand is that the next step for a patient who presents an airway concern is a home sleep test. If they go to a medical facility, if they go to a sleep physician, if they go to a sleep center, it doesn't matter. If they present with these signs or symptoms, the next step is a home sleep test every single time. No different than if a patient presents pain in their tooth, no different than, if you find something that looks suspiciously like a cavity. I want you to think about home sleep testing like an x-ray. You wouldn't diagnose a patient without an x-ray or a cone beam. You wouldn't quote fees to a patient without an x-ray or a cone beam. You wouldn't even talk to patients about the specific treatment options in light of it being a diagnosis because you don't know the diagnosis. A patient says, "Hey, Dr. Smith, how do I, what, if that is a cavity, how much is it to fix it?" And you're like, "Well, I don't know. If it's a cavity, and I can do a filling, it's this. If it needs to do this kind of material, it's that. If it's a crown, it's that. If it's a removal and an implant, it's that." It would be irresponsible to quote fees at that point. The same thing is true for sleep apnea treatment. Whether it's snoring, upper air resistance, sleep apnea, or they need a CPAP, you can't quote those fees. You don't even provide CPAP. They might need surgery. You can't quote those fees. It's irresponsible, and it's a disservice to your patient to jump ahead of the process for sleep. Now, hopefully you can provide a therapy in your methodology, the appliance, but don't jump ahead of the game. It's not appropriate to quote fees or even tell them about sleep apnea unless they have sleep apnea. That will scare them. That will make them think they don't have the problem. So in this conversation, doctors, hygienists, dental assistants, front office folk, we do not quote fees, we do not provide diagnosis, and we do not talk about treatment recommendations until the patient has a positive test diagnosing them with the condition, and we have a recommendation from a physician to move forward in treatment. Very important. It could be a liability concern for you otherwise. So there's my TED Talk about quoting fees. Sorry if that's beating a dead horse, but it's critical that we know that screening patients for sleep apnea, the next clinically appropriate step is a home sleep test. Doesn't matter where you get the test. That's the next step. So let's jump into our protocol. First up, this is going to be my handy dandy forms reference. I'll use this a few minutes. It's actually, I found out, my home sleep test I did last year, so that's kind of fun. That said, our patient today is going to be Mrs. Smith. Now, Mrs. Jones, because we have Dr. Smith. Mrs. Jones is our favorite dental patient. She's a patient who, despite our protests, continues to bring a pan of brownies to our practice every single time. And we protest. You know, we are dental practice. We're really not supposed to eat sugars, but yet every time she leaves, the brownie pan is empty. That's Mrs. Jones. She's not young, but she's not old. You know, say late 50s and mostly retired. Okay, that's our patient today. I'm going to be Chad, the hygienist, again over here. Dr. Smith will pop up a little while later. Now, Mrs. Jones comes into the practice. She fills out our forms. We haven't incorporated any screening forms. We're just doing medical history. But our front office team, they write the letters AI on the front of the route sheet and hand it to Chad, the hygienist, as he's walking Mrs. Jones back. Now, as I'm walking Mrs. Jones back to my chair to go get started with their cleaning, we just start talking, and she reveals to me that lately she's been struggling with her daytime fatigue. Now, as I noticed the AI on the corner of the route sheet, I sit down and we're talking a little about how the grandkids are and how she noticed the daytime fatigue because she was getting tired while driving. And right before we do our hygiene check, I want to do a quick oral exam just to see how everything's going. And so this is what I'm going to say. I'm going to say, Mrs. Jones, real quick, I'd just like to do an intraoral exam. Can you open your mouth? I'm just going to look inside. And as looking inside, I see that she's got some bruxism. I see that she's got some tongue scalloping. And so we already knew that. We've already talked about her bruxism, but it hasn't gone away. So she's not really wearing her mouth guard she bought from us. And at that point, I remember, oh man, I got the AI on the sheet. So I look over, and on her medical history, I find that she's got hypertension. She's pre-diabetes. Oh, if you didn't know, you can do fun things. I'll show you how to do that later. But she's got pre-diabetes, she's got hypertension, and she's been suffering from morning headaches. She put on her airway questionnaire that we included after this training. So pop quiz real quick. How many signs or symptoms did Mrs. Jones have? How many signs or symptoms did Mrs. Jones have related to airway? Let's go through. Hypertension, pre-diabetes, morning headaches, daytime fatigue, bruxism, tongue scalloping. We have 6 things that Mrs. Jones, yes, Daniel, 5 stars for participation today. Thank you. 6 things that Mrs. Jones has at risk. Now, what you're not going to do, to be clear, is provide a laundry list of things that are wrong with our patients, especially about sleep and airway, because that can come off really, really poorly. We're going to pick our 3 favorite things, hence the name of the protocol, and bring those up to Mrs. Jones. Now, as you get better at this, I want you to focus on the things that are most impactful for our patient. That likely, in this instance, is going to be those morning headaches, the drowsy driving, and her bruxism. Those are the things that are having the biggest impact on her day-to-day life. And we're going to use that to start a conversation. So we've gone through all this stuff. And now, hygienists, if you're a hygienist here, or doctors, pay attention because you need to tell them how to do this. This is what we're going to say. Hey, Mrs. Jones, you know, as we're just getting started with our cleaning, I couldn't help but notice with your medical history and the morning headaches, the fact that we had talked about just daytime fatigue and the frustrations there, and then also with the grinding, I'm a little concerned about your airway. I really think there could be something going on there, and I think you should do a home sleep test. Real quick, there's a little raise hand icon deal on the Zoom window. Whose hygienist can do that? Can I get a thumbs up, a raised hand, something like that? Let me see who's here tonight and whose hygienist can have that simple conversation. Absolutely. Awesome. At least 2 of you are paying attention. All of you, thank you, 4 of you, all of your hygienists should be able to have the conversation. When they ask that question, they just need to pause and wait for the patient to respond. The patient will say yes or no, or I'll think about it. It doesn't matter, because after that, they're going to add the treatment code to their software and then move on with their hygiene check. That's it. They're done, at least for the first part. Now, if you have a very sensitive office and they're not used to patients saying no, then you can absolutely give them a break, let them go cry it out, and then when they're ready to come back, no, that's not going to happen. The hygienists present treatment all the time. They're used to bringing up stuff that's concerning to them and having that dialogue with the patients. The trick is we got to keep it short because otherwise it's hard for them to do that. So that should take 30 seconds. We're done. The patient says, you know what, I'll think about it. Then you go on with your cleaning. We clean the patient's teeth. At the end of our visit, the doctor comes in to the appointment, and Chad, the hygienist, goes through dental considerations. Hey, Dr. Smith, Mrs. Jones has some pain on number 8. She's got number, I don't know, 10 has something going on, and number 47 doesn't exist. And Dr. Smith's like, 47. We'll talk later. Okay, yeah, number 8, that one looks like a cavity. Let's get an image of that. We'll see what's going on. Number 10, yeah, that's an ugly tooth. Let's just done. I'm just kidding. I'm not a dentist. So you would do your normal treatment planning thing that you do best. And then at the end of your dental exam, doctors, very important, you're going to look at the hygienist in front of the patient, very important, in front of the patient. And I want you to say something just like this. Is there anything else we need to talk about? What we're doing with that small little piece is that we are now in front of the patient, kind of closing up the dental conversation. We're taking off our dental hat and putting on our sleep hat or our airway hat. We're transitioning to the conversation. Now, again, this goes into that how many times can we get this in front of the patient thing I talked about at the very beginning. We need to go 7 times. After this point, the hygienist is going to respond. Now, I'm going to start the timer. I'm going to do this, and we're going to pretend that Dr. Smith had just said that prompt. But I want you to pay attention to the first thing I do after I clack. Ready, set. You know, Dr. Smith, I was talking to Mrs. Jones earlier, and I couldn't help but be concerned about her airway. On her medical history, she had noted some headaches, morning headaches. And then as we were talking, she shared a little bit about how she's just been feeling some daytime fatigue, specifically in driving. And just with her grinding, I was really concerned about her airway. And I just was hoping you could talk to her about that. Pause real quick. What was the first thing I did after I resumed time? I stopped. I didn't say anything. In fact, I took a big breath. This is called a pregnant pause. Now, if you have kids, then you know that a pregnant pause is often used to give someone in trouble. When you saw my niece, I also have some brothers that are a couple generations younger than me. We won't talk about that story. But when they were younger, Jacob and Jeremy would get in trouble. They're in middle school and high school now, which is bonkers, but they get in trouble. And I found out with my voice, if I raised my voice, they would just kind of disappear. And so I stopped raising my voice and I would just say, Jacob. And he eventually got smart and started running away with that response as well. But he knows that something is going on. Think about when you go to the doctors. Chad, we can't fix stupid. Whatever your medical concern is, we know that bad news comes after a pause. The pause means the bad news is coming. And so here, hygienist, my challenge, my question, my request to you is very simple. Can you pause for 2 to 3 seconds or 3 to 5 seconds so that we have a better chance of saving 7 to 10 years of our patients' lives? Untreated moderate to severe sleep apnea will cost our patients between 7 to 10 years of their life. And we have data that shows that pregnant pause has a much higher chance of converting your patient to a home sleep test. So to recap what we did, we pregnant paused. Then the second thing we did was we restated the same exact 3 things from earlier in our conversation. For our example with Mrs. Jones, we have the morning headaches, we have the drowsy driving, and then we last but not least, we have that bruxism. Now, I do this a lot. I mentioned in the morning headaches because it brings physicality to it. That's a little tiny nuance in treatment planning. It could help. But when we look at that, this is the same 3 things. So we're getting closer to that 7 times of bringing this up to our patient. Doctors, your part is just as important. And if you do it wrong, your hygienist is going to be mad at me. So pay very close attention to what I'm about to tell you. You're going to look at this patient like you've never seen them before. You're going to do this. You ready? Mrs. Jones, real quick, can you open your mouth? I just want to take a look at the bruxism. Okay, yeah, I see that. And tell me a little bit more about these morning headaches. Okay, just for about 30 minutes. And okay, cool. And drowsy driving, it's usually in the afternoon, is that right? Okay. Mrs. Jones, patients who present signs and symptoms like this, the morning headaches, the daytime drowsiness, and then also the grinding in combination with one another, means that they're at risk for an airway concern. The next step for you is to actually do a home sleep test, and that will help us evaluate to see if your airway is causing some of these dental considerations and also the other symptoms that we're looking at. Do you have any questions? Doctors, address the concern. Make the concerns a little louder. Restate the diagnosis, the fact that they are in fact screened as identified as at risk for an airway concern, and then do what you always do, recommend the next appropriate step. The next appropriate step, and I hit on this super hard earlier, I'm gonna hit on it again right now. The next appropriate step is to do a diagnostic home sleep test. Yes, you have to be asleep to diagnose sleep apnea. Yes, home sleep tests are reliable home devices for diagnosing. Most of them are, I should say. There's some question about other devices out there, and that's a whole nother topic as well. But that is the next appropriate step. And then doctors, Zivit, wait for the patient to respond. Let them say yes, and then move into your protocol from there. Are you doing a third party? Do you have your own equipment? Are you referring to a local lab? Whatever your protocol is, put them into that. Pro tip, if you want your team to do this, make sure that you have a protocol to give them to get that patient into the next step. So two-minute recap. Are you ready? Patient walks in, front office marks our medical history. From there, we talk to the patient. We find up to three things that our patient is at risk for. Mrs. Jones, I'm concerned about 1, 2, 3. I think you should take a test. Mrs. Jones says no. We do our cleaning visit. Doctor comes in. Doctor, here are our dental concerns. Is there anything else we need to talk about? I talked to Mrs. Jones earlier about 1, 2, and 3, and I'm concerned about her airway. I was hoping that you could share with them more on that. Mrs. Jones, patients who have 1, 2, and 3 are at risk for an airway concern. We'd like you to not die sooner, and as such, you need to take a home sleep test. Do you have any questions? I'm just kidding. Take out that little sarcastic remark there. Unless you really want to have fun. I have some patients that I would say that too. But that is our screening protocol. So with that, again, remember, we got to have a clear protocol. We've got to have our team buy in, and we got to make sure that we take care of our patients. Patient care is number one. Whew, that was a lot. I went through a lot without slides, and you survived the three. We have a joke here that's called the 3 personalities of Chad, but the 3 favorite things protocol. So with that, I want to make sure to open up for any questions. If you guys have any, Daniel did ask, where can we get the screening forms? Feel free to email me. You can also email the True Function team. They have access to the Awaken2Sleep screener, and we have a variety of forms that we can give you for free as well. Last thing in this list is in the event that your patient does not say yes to the home sleep test, then this is open treatment. It's declined treatment. You recommended that the patient does a test. If you recommended the patient does a cancer screening and they said no, you would document that. If you recommend they do an x-ray or a cone beam and they said no, you would document that. This needs to look just like any other service that you provide in your dental practice. So that is your deal. My email is chad, C-H-A-D, at awaken2sleep.com. Yeah, just my name at our website. So with that, I'm actually asked Trish to come up here while you guys are thinking about your questions. If not, we've got a couple more slides and your CE link coming up in just a moment. So Trish, I know we have some really cool stuff with this appliance here. I don't know much about it other than it looks really cool.
Yeah, absolutely. So pretty special to True Function. We use the acetal material quite often. It is a wonderful device, a material to use for device because it's so small, and patients love it with it being so compact. And so we're promoting that appliance this month. We really want to get that in your guys' hands so that you have a chance to learn and get familiar with that specific material. So we're running a 25% off discount this month for the acetyl dorsal appliance. It does typically on the end of the month, but we are going to extend it till next Friday for you. So if you want to get your hands on a dorsal, get that ordered by next Friday. If you're not a current client with us, I will put a link in our chat where you can fill out a new account form and get set up with us. If you have any questions on that appliance, feel free to email me. I'm happy to explain any of the details on that dorsal or the material or anything like that.
Cool.
Yep, thank you. So we would love for you to have you. We would love to have you join us for our next webinar, specifically on the ins and outs of repositioning occlusal appliances. So this is with Dr. Brajesh Chedwani, Wednesday, March 27th. You can actually use that little QR code right on the screen, or go to our education page on our website, and that'll take you right to the registration page where you can join us again next month. So we want to thank you, Chad, of course, for joining us. We really appreciate Awaken2Sleep and our partnership with you. And I know he's going to answer some questions here shortly. So stick around while he finishes things up, and feel free to put those questions in the question box.
Yeah. One last resource from me as well, folks. We went over a lot of stuff. I talked about your team a ton. One, you can get the QR code on the left-hand one with the Awaken2Sleep 2 in the icon. And the one with the faces talking, that one is a free coaching call. If you'd like to connect with our team, I can't promise it'll be me. If you want to talk to me, you got to email me. But our team of coaches are there, and we want to help you out. Just speaking from personal experience, your practice has so many people who need help. We're talking hundreds, if not thousands, of patients who need your help. And the only thing in their way of not getting treated for sleep apnea is the fact that they don't know it's a problem. And you could be the reason their life gets saved. So with that, just please make sure to take some time and screen your team, screen your patients, and start to have those conversations. And if you need any help, please make sure to reach out to us or Trish at True Function or Frank at True Function. Just talk to your partners in sleep. We are all here to help you out and do more. So with that, we're going to stick around for a few minutes, answer any questions you guys have. Apparently, I just did a fantastic job of presenting because we only had a couple questions. I'll show you one other thing. You guys saw this little Zoom deal, Leo Bob, that popped up, that one. If you have a Mac computer, you can do other things. For example, my favorite, if you put up this laser show. So you're welcome. There are others. Double thumbs up is another one. I think, yep, fireworks. All right, there you go. Bonus for your CE course tonight. The CE link is in the chat, as well as the True Function webinar for next webinar. Please take a second to go register for that. There's nothing quite like clinical education to help bring your treatment up. So, Trish, I just killed it tonight. No one has any questions. So,
Wonderful.
yeah, do you have any? Oh, here we go. Josh, thank you. What do you think about the biggest roadblock patients create other than ignorance, and how do you think it's best to overcome this? The biggest roadblock when patients create, objection handling is the most popular topic that we keep to coach on in our company, because patients have objections, and the reality is that patients don't want to have a disease. They don't want to think that anything is wrong with them, and frankly, most folks are comfortable in their misery. It's a hard way to say that, but when you're tired, you feel justified in a lot of the things that you do. And so the problem with patients and roadblocks is that, they don't want to give up their laurels. They don't want to say, I have a problem and I want to fix it. And so we've got to connect that pain and show them how to overcome that pain, the fact that the pain isn't part of their identity. So I would say, to sum it up quickly, the biggest roadblock is that patients' pain is often related to their identity. They are a snorer. They are someone who sleeps soundly, who can fall asleep at the drop of a pin. That's part of their identity. And if you're trying to attack that thing, if their sleep is a problem, if their snoring is a problem, if their tiredness is a problem, you've actually just said that they're a problem. So there's a framework that we've got to separate the patient's pain from their identity and then help them see a positive alternate outcome. It's called the hero positioning framework is what we teach it as, and it is the number one problem, and most objections revolve around that very big concept. Beverly asks, can we get a presentation to share with our team at a staff meeting? Sure. I believe Trish records this,
Yep.
so you guys can do that.
this is
Show
a-
them this. If you don't like my jokes, then yeah, we can get you a copy. I thought my jokes were pretty good. I'm just kidding. Joking.
They're great.
Yeah.
They're
Yeah.
great. Yeah, Dr. Thurman, this is being recorded. So everyone that registered for the webinar today, you will get the recording. I would expect that no later than early next week. So keep an eye out in your email. It'll say webinar recording as the subject line. So everyone will get a copy of that, like I said, by early next week.
Awesome. If there's any screen resources you're missing, again, shoot me an email, go to our website, tell them that you attended the True Function webinar. To be clear, we don't usually give away free stuff, but we love working with True Function. So we're happy to give away a couple extra resources as we can.
Chad, thank you so much for the wonderful information that you've shared. It's amazing as always. So we really appreciate you coming on. And
Cool.
everyone,
Well,
thank you for joining us this evening.
awesome. Well, have a great night, everyone. I look forward to seeing you guys on the next one, whatever topic that is. And you guys have good luck screening your patients.
See you soon, everyone. Thank you.
Thanks, Chad.
Thank you, Trish.
Thank you, everyone. Have a good evening.
Thanks again, guys.